Good morning and welcome to the JASN podcast, where we highlight an interesting recent paper from the journal. I'm Dr. David Ellison, Professor of Medicine and Chemical Physiology and Biochemistry at Oregon Health and Science University and a Deputy Editor at the journal. I'm joined today by Drs. Anna Zemke and Nisha Bansal from the University of Washington to discuss their paper entitled Accuracy of Identification of Cardiovascular Events with International Classification of Diseases Diagnosis Codes versus Physician Adjudication in CKD and Kidney Failure. And this appears in this month's edition of JASN. Dr. Zemke and Bansal, please introduce yourselves and tell us a little bit about your background.
Hi, I'm Anna Zemke. I'm currently a clinical nephrologist at Swedish Health, part of the Providence Health System. And earlier this year, I finished my clinical research nephrology fellowship from the University of Washington, where Dr. Bansal was my co-author on this paper and also my mentor for the last couple of years.
Yes, and thank you, Dr. Ellison and Jason, for recognizing our paper. My name is Dr. Nisha Bansal. I'm a professor at the University of Washington. I'm a nephrologist, a physician scientist who studies cardiovascular disease complications in patients with CKD.
So I must say that one of the reasons that I chose this paper to discuss is, first of all, it was very interesting, but I was a little surprised by the top line results, and we'll get to those results later. But could you set the scene for the listener by discussing something about the challenges with respect to cardiovascular disease in CKD and the background for the central hypothesis and also your approach to the questions?
Yeah, so setting the background for this study, cardiovascular disease is highly prevalent in individuals with chronic kidney disease and has a high morbidity and mortality. Those with CKD, they're more likely to die from cardiovascular disease than kidney failure itself. And so all of this makes cardiovascular disease an important endpoint in research studies. In our study, we looked at 4 different outcomes: heart failure, myocardial infarction, stroke, and AFib. So especially for heart failure and MIs, there are clinical diagnostic challenges in individuals with CKD, including alterations in biomarkers, overlapping symptoms. For example, patients with CKD, they often have edema or shortness of breath, but it's not clear if it's truly heart failure. So for this reason, physician adjudication with well-defined and set definitions has been the gold standard for outcome identification in research trials. But as expected, physician adjudication, it's quite resource intensive. And so considering alternative approaches to ascertain these cardiovascular outcomes could improve the efficiencies of studies in people with CKD, including clinical trials. And so this is what led us to our central question of the study: really, how accurate are clinically used ICD codes compared to physician adjudication in a CKD population? So for each of the 4 outcomes mentioned, we determined positive predictive value, negative predictive value, sensitivity, and specificity. And we looked at this both in the primary ICD code position, as well as including all the secondary ICD diagnosis codes.
Great. Well, for the study, you utilized data from the chronic renal insufficiency trial, the CRIC trial. And for those of us who don't typically use such large databases from large longitudinal studies, could you tell us something about the populations you studied? And I was especially interested in the fact that you excluded people with polycystic kidney disease, or at least that's what I took from the paper. And I wondered why that was. And also you included folks with heart failure in class 1 and 2, but not 3 and 4. So just wondering what your reasoning was about some of those exclusions of the study population.
Yeah, great question. So yes, we worked with a chronic renal insufficiency cohort study. It's a large, multi-center observational cohort of nearly 4,000 patients who have CKD and were recruited from 7 clinical centers. And it's a clinic-based population, meaning everyone was being seen in care. Patients were recruited into the study between 2003 to 2023, so over a 20-year period. The primary goal of the study was to examine risk factors for progression of CKD, and so that was the benefit of following patients for so long, as well as to look at development and worsening of cardiovascular disease in this population, which really provided us the key data that we needed to do this study. And part of their process was to perform this rigorous physician adjudication of all cardiovascular events. And what that means is that for every hospitalization for cardiovascular disease, 2 physicians independently reviewed each of those hospitalizations and used standardized criteria to see if the hospitalization itself was truly a heart failure or a MI or atrial fibrillation or a stroke event. And the physicians had to agree on their assessment. The inclusion criteria and exclusion criteria are interesting, and thank you, Dr. Ellison, for noting the exclusions related to polycystic kidney disease and some other things like advanced heart failure. These were predetermined by the CRIC study at the time of enrollment. And so we did not exclude anyone in addition to who were already excluded for inclusion in the study. And so these were pre-existing inclusion exclusion criteria. I will note that CRIC offers a lot of benefits in terms of how large it is. It's a multi-center study. They're really well characterized, but it is important to note that it is a clinic-based population, as I mentioned, so it may not be completely generalizable to other CKD populations. So please keep that in mind when thinking about the findings.
Yeah, okay, great. And you've sort of answered this question already, but I assume that the adjudication was built into the CRIC study, and you've said that it was long before your study was conceived. And you also mentioned the fact that adjudication, which I'm sure is takes a lot of time and effort, is a very resource-intensive effort. And it sure would be great to have a less resource-intensive but accurate method. And if we could use ICD 9 or 10 codes, I assume that would be great. So I'm assuming that that was the reasoning or the background behind your study. You also sort of alluded to this, but for me, looking at the study subjects, it does look like a pretty representative group of patients with CKD. Is there anything special other than the things we mentioned about the exclusions that you highlighted actually came from the CRIC exclusions? Is there anything else? And you said about the fact that this is a clinic population. Is there anything else about this population that you think is unusual or not representative of our general population of CKD patients?
I'll jump in and answer that one. So I think that in general, these patients were older in age and had a lot of similar comorbidities that we see in patients who have CKD. Of note, CRIC in the design of the study did over-recruit patients who had concomitant diabetes mellitus, about half the population. In addition, I think I would note that the patients were very well treated. Most of them were on RAS inhibition, for example, or being treated for hypertension, and their mean systolic blood pressures were all fairly well controlled. So again, reflecting that this was a population that was receiving care.
Great. So the first outcome listed in your paper was heart failure. To me, what struck me was just looking at the ratio of coded events to adjudicated ones for heart failure. And as I looked at the paper, it looked like there were about 1,507 coded heart failure events and 2,477 adjudicated ones. You then calculated predictive values and sensitivity and specificities. If you could just discuss a little bit about both the findings here and how you interpret them.
Yeah, so looking at heart failure, we found a positive predictive value of 79% and negative predictive value of 96%. And what this tells us is that if there was an ICD code for heart failure, it likely is true, heart failure. However, our sensitivity was 48%. So we may be missing or likely are missing some cases of heart failure when we're using ICD codes versus physician adjudication. I think an important point to put these numbers in context is that these are for primary ICD codes. So when a clinician is billing or coding, this should theoretically be the main reason the clinician determined for this hospital admission. We did do a secondary analysis as well, where we looked at all available ICD codes. And for that, as expected, the sensitivity was much better, near 90%. And so this tells us that, for certain studies, using ICD codes beyond this primary position is going to help us better detect more true heart failure cases.
Thanks. So the next outcome you evaluated with myocardial infarction, and sort of as expected, there were many fewer of these events. But just my own clinical practice, I think it's sort of hard to define heart failure, and especially in CKD patients. I'm not sure I even understand what the difference between volume overload in a CKD patient is and HFpEF. But myocardial infarction seems clearer. So I was surprised that, again, your sensitivity was near 50%. I would have thought that coding for MIs was maybe clearer than coding for heart failure. But it looks like a lot of people weren't classified according to ICD-9 codes or 10 codes as having had a myocardial infarction. Is that correct?
Yeah, that is correct. Your interpretation is right. I think we were surprised by this as well. Certainly clinically, we do see more conundrums about the diagnosis of heart failure in patients with kidney disease. However, when looking at our data, even MIs can be very tricky to diagnose in patients with kidney disease, which may lead to these lower rates of coding for an MI. For example, some of the diagnostic criteria that were used in adjudication are elevated troponins. And we know that troponins are frequently elevated in patients with kidney disease due to reduced clearance of the circulating biomarker, which makes levels difficult to interpret. Symptoms can overlap. Shortness of breath, which are often indicative of an MI, may be difficult to interpret in the setting of chronic kidney disease. And so for, I think, all of those reasons, we're seeing lower sensitivity with ICD-9 codes and 10 codes for MI as well. And this was fairly consistent even when we used all ICD-9 codes, including secondary ones, where we found fairly low sensitivity for MI.
Yeah, I think that's really interesting. So for stroke, the results seemed quite similar, at least in terms of sensitivity. But when you got to atrial fibrillation, there was the biggest difference. So here, the sensitivity of coded diagnoses was only 15%. And it seems to me like that must somehow reflect how people code patients when they're in the hospital. Could you discuss this finding and suggest reasons for it and perhaps ways around it in the future?
Yeah, you're right. Atrial fibrillation definitely had the lowest sensitivity when looking at these primary ICD codes of 15%. So this is really telling us that clinicians rarely used AFib as a primary diagnosis code. And I think one important thing to note is that the AFib diagnosis didn't have to be new in CRIC. And so, any AFib during admission could be documented by the adjudicators. And so if you think about this, chronic stable AFib, clinicians likely wouldn't place this in the primary diagnosis code. And, this is one reason we did see AFib. We found the largest change in sensitivity between primary diagnosis code only versus all diagnosis codes, meaning again that, clinicians weren't putting it first. It was, kind of a little bit in the background for a lot of these patients.
Great. So you go on to discuss the correspondence between diagnostic approaches, and you discuss the, quote, Cohen-Kappa coefficient with bootstrapped CIs. So those words are kind of Greek to me. I'm not a ClinEpi guy. So can you explain how these terms are defined and what exactly they tell us?
Yes. And so I will also admit that I didn't learn about this test in my master's biostatistics course. And, we very much thank our excellent biostatistician, Dr. Leela Zalnick at the Kidney Research Institute, who helps us on this study and many others. But basically, this analysis was to provide another measure of strength in inter-rater agreement. So in this case, the agreement between events identified by ICD codes and those identified by adjudication. And the bootstrap confidence intervals, that allows us to provide an estimate of the variability around the data we found. So, making that range of confidence intervals. So we found the Cohen's kappa coefficients were near 0.6 for heart failure, MI, stroke, which, the method is on a scale of 0 to 1. So it suggests moderate agreement, while AFib was just 0.23, suggesting fair agreement. And this, is similar to what we see with the lower sensitivity, for example, in AFib as well.
Yeah, that makes sense. So one of the things I thought was kind of interesting, and I'm interested in how you interpret it, but you noticed that the sensitivity across the board was lower with ICD-10 codes than ICD-9 codes. And my assumption was that the reason we moved from ICD-9 to ICD-10 was they're supposed to be better, but that kind of suggests, at least in terms of discerning diagnoses, they're not as good. Yeah, can you speculate about that at all?
I have to say this was surprising to us too, and which is why we did this additional analysis, was to tease out the ICD-9 versus 10 codes. So to remind everyone, ICD-10 codes were implemented in 2015, so 10 years ago. And in the context of the CRIC study, they were implemented partway through the study. CRIC started enrolling patients in 2003, so 12 years after patients were already in the study. And so this is an important point because we didn't have as many ICD-10 code diagnoses as we did ICD-9 based on the available time of follow-up. So keep that in mind when interpreting this. I would say that in comparing our results to other populations, non-CKD populations, there also have also shown variable results in comparing ICD-9 versus ICD-10 codes, where ICD-10's not clearly being superior. I do think that this is an area that needs further investigation and validation before we can say with confidence that ICD-10 codes are not better than ICD-9 codes.
I never would have expected that.
Yeah.
The main thing I knew about ICD-10 is you have left and right more. So maybe it makes people miss things more. I don't know. In the discussion, you note that the positive predictive value for heart failure is lower in patients with kidney failure than CKD. So I wasn't surprised at this observation. I think I mentioned this already. I think most people with ESKD run around chronically volume overloaded all the time. And I just wonder, in ESKD, how do you is heart failure different from volume overload? And how did the adjudicators differentiate those?
You're right. We found heart failure, the positive predictive value for kidney failure participants was 75% compared to 80% for those with CKD not on dialysis. For the reasons you just stated, we actually would have expected a bigger difference between these two groups. But the CKD group, we did have a range CKD stages, and so this also could have contributed to that similarity. In terms of, your other question about adjudication of volume overload versus a heart failure event, Nisha, do you have any insight into specifics?
Yeah, Anna, thank you for the question. So, to create the adjudication forms, the study took established criteria that were used in other populations, such as the Framingham Heart criteria, and modified it for CKD. Partway through the study, they did try to add questions around, is this volume overload versus a true heart failure event? It wasn't captured consistently for everyone, and it was hard to tease out. I think clinically we struggle with this, and as an adjudicator who has access to the medical record but not the patient, I think the struggle was even greater.
Yeah, it just does recall the fact that many years ago after ALLHAT, that one of the outcomes there was heart failure. And that was one of the areas where the diuretics were better than the other drugs. And there was a huge discussion in the literature about whether they were just calling volume overload heart failure. And so and that was in patients without severe CKD, as I remember. So just moving on, I think to the probably the most impactful part of the study. At the end, you suggest that the relatively high negative predictive values of the codes means that the codes may best be utilized for certain types of studies. So maybe you could play out a little bit, what uses do you think we could take ICD-9 or ICD-10 codes and maybe improve the efficiency or reduce the cost of studies without sacrificing accuracy?
Yeah, and so I will say, one of the strengths of this study is the amount of data we're able to provide for researchers. We have 4 different types of cardiovascular outcomes, and we also use this ability to look at both primary codes alone or all ICD codes. We definitely do see differences between adjudication and ICD code in terms of event ascertainment, but this is going to matter more in certain research studies than others. Examples I can think of, pragmatic studies with large populations, with limited resources, using ICD codes where the positive predictive values are near 80% could very well be good enough because you have such a large sample size. With high negative predictive values that we saw, you can be fairly confident that a specific cardiovascular disease event did not occur. On the other hand, an example where ICD codes may not be sufficient are in studies where you would want to make sure you're capturing all cases of the cardiovascular disease event. For example, studies where you're focused on screening, for example. And so really, at the end of this, there are pluses and minuses for each approach, and the investigator is going to need to carefully consider what works best for their study question and also the resources they have at hand. Our goal was really to help provide this new information to help inform these decisions for researchers moving forward.
Yeah, I think this was incredibly sort of practical, relevant study when I read it, and that's why I thought it was so interesting. It did bring up one final question, which you can just speculate on freely if you want. ICD-9 codes are used with respect to billing, and they're a key part of billing. So I wondered whether the relatively low sensitivity tells us anything about how accurate our billing is in this country and whether there are ways to make that better.
Yeah, I can speculate a little bit about this. I think we all think about this in our routine clinical practice. I think we're at an era of change right now with AI tools being used more. I think there's going to be more adaptation of AI for documentation. There'll be more automation of abstracting billing codes from these records. So I think this is an area of flux, and we'll learn more about how we bill, how we document in medicine, which will certainly affect how we capture diagnoses for these EHR type-based studies.
Yeah, great answer, and I hadn't thought of it that way, but I think that's a sharp reply, and we'll have to see what happens because we're all going to be working with AI in the future. At any rate, thank you both so much. As I said, I thought this was a very interesting study to read and very practical, and I hope you continue to work on projects like this in the future. Thank you so much.
Thank you so much for the opportunity. Really appreciate it.
This podcast is copyrighted by the American Society of Nephrology. All rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare professional if you have any questions about any medical condition or before taking any drug, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast from the American Society of Nephrology.